Thank you.
So I'm happy to welcome Caroline Glendinning from the University of York.
Thank you. Okay, yeah. So I'm going to drill down a little bit and talk to you a bit much more about people's experiences as they use their PHBs. I'm going to talk about the outcomes, why they were positive, how those positive quality of life outcomes that Julian talked about were achieved. I'm going to talk a bit about people's experiences of the implementation process, and in particular, the factors that could help to increase the positive benefits and the problems that could reduce the benefits of personal health budgets. And then move on from that to talk about the rollout, the implications for the wider rollout of PHBs. So we interviewed a subsample of people who'd been recruited to the main evaluation. We initially recruited 58 people, interviewed them at 3 months. These interviews at 3 months after they'd been offered a budget were very much around their experience, their early impressions, their early reactions and responses to the offer of the budget. And then we re-interviewed most of them again 6 months later, when most of them, as you'll see, the majority had budgets in place, and they were actually able to talk about what difference that had made to them. You'll see that the subsample included people from all the main healthcare conditions that were included in the pilot. And yeah, you'll see that by the time of the 9-month interviews, most of them had had their budgets in place for at least 3 months. We also interviewed some carers, and these carers of people who'd been offered personal health budgets. And we interviewed a subsample of 10 women from one pilot site who'd been offered personal health budgets for maternity care. The 19 carers who were interviewed, and then down to 13 at 9 months, we wanted to talk to them about their experiences as carers, not what they thought of the effect the budget had had for the patient, but about how it had impacted on them as carers. And we included carers of people supporting people who'd had strokes, COPD, long-term neurological conditions, and NHS continuing care. And particularly those last two groups, the long-term neurological conditions and continuing care, most of those carers were providing very, very substantial amounts of support to patients. So, just looking at the budget holders to start with, as I said, there were 52 who we interviewed 9 months after they'd been offered a budget. They had, most of them, vast majority, had had their budgets in place for weeks and sometimes several months. The overwhelming impression was of better health, better physical health, better mental health. They'd use their budgets mainly to employ carers or personal assistants. They'd use them for gym membership or exercise classes. They'd use them for complementary therapies, alternative therapies. A few had used them for computers or social activities. But most reported these better outcomes, feeling better. Now, I just want to elaborate on that for a little bit. Significantly, the benefits extended beyond the particular condition for which the budget had been awarded. So, for example, somebody with a mental health problem, offered a budget, used it for gym membership, lost weight, felt physically better, as well as having improved confidence, able to go out more, feeling more confident about themselves more generally. Somebody experiencing pain as a result of a neurological condition used it for complementary therapy. The better pain management also helped to reduce symptoms of depression. So there was this really clear crossover. It wasn't just, improved physical health, improved mental health. It was much more global. It was holistic. And the benefits that people reported often exceeded their initial expectations. Other benefits that people talked about included a better motivation to manage their symptoms and manage their health. Some people talked about fewer visits to the GPs. People talked about fewer prescriptions or perhaps over-the-counter painkillers. And some people reported feeling that they were getting on better with healthcare professionals. One of the reasons why people felt these benefits was that they had experienced more choice and flexibility over their healthcare. Typically, people who are eligible for continuing health care or who had very high support needs were able to employ their own personal assistants and their own carers, and that gave them control over who provided their care, when, and what times, and so on. People also talked about the benefits of flexibility, so being able to purchase physiotherapy and have appointments at times that suited them, fitted in with their lives, rather than having to go at a time they were given. And people really appreciated being able to access services that were not normally available through the NHS, like gym membership, complementary therapies, and counselling. There were wider spin-off benefits reported as well. People talked about better relationships within the family. Partners and spouses worried less about them. They were able to join in family activities more. And partners, for example, were able to get a good night's sleep because the patient's pain was better controlled. So a wide range of benefits there. And I hope, some ideas hints as to how those benefits were achieved. The issues around implementation are quite important because a poor experience of implementation could reduce those benefits. And I think there are really big lessons here in terms of the wider rollout of personal health budgets. I do have to emphasise, though, that these particular patients who were interviewed were recruited fairly on in the pilot programme. It's possible that some of the delays and bureaucratic hiccups might have got ironed out later on. So these are representative of the early budget holders. So as Julian said, one of the really important principles underpinning personal health budgets is that you should know how much your budget is. But a minority of the people who we interviewed didn't know the level of the budget, they didn't know how much they'd spent, and they didn't know how much was left to spend. Some people didn't appear to understand the concept of a kind of personalised resource allocation. Some people talked about, well, there's a collective pot of money, and if I underspend, well, that's all right, because it'll be there for somebody else. They hadn't grasped this concept that it was their budget for them to manage. The Department of Health consistently emphasises the crucial role of information and advice to people in planning how they're going to use their budgets. And most of the people that we interviewed were very happy with the help that they'd received. A few wanted more information, though, on what might benefit their condition, or who were the best local providers to go to. Some people had been offered a kind of menu of, well, these are ways in which you could spend your budget, and they found that really helpful. Those suggestions were really helpful, but it was emphasised that what was helpful was that they were suggestions. This was not a definitive list and an exclusive list of what they could spend the budget on. They also found it really helpful being given ideas derived from how other people had used their budgets, particularly other people with the same condition or in similar situations being suggested, suggestions of, well, so-and-so found this was helpful, you might like to think about that. They found that really helpful. The group of people who found it difficult, particularly difficult, to plan how to use their budget were those who'd been offered it very, very quickly after a major health event. So typically people who just had a stroke were still in acute hospital inpatient wards, offered a budget, and they found it really hard. They found it really hard to imagine, well, how is my life going to be different? What impact is this stroke going to have on me? And how far am I going to get better? And that kind of level of uncertainty was very, very difficult in terms of planning how to use the budget. Again, this may reflect something about the early stages of the pilots, but there was widespread uncertainty about what the boundaries were for spending personal health budgets. What was legitimate and what was illegitimate? I mean, the Department of Health has given some very broad guidelines on that you spend your budget on anything that is legitimate and safe, legal and safe. But within that, individual pilot sites seem to be imposing certain sorts of rules or restrictions, and people were really uncertain about that. And the problem was that created problems when their support plan went back to the PCT to be approved, and some people would find that things they'd thought this would really benefit me was those things were turned down, and they just didn't know where the boundaries were. It caused them to be frustrated. It caused them to be angry. Some people had been on the Personal Health Budget website and knew that the things that they were asking for that had been turned down had been allowed in other pilot sites. And they didn't really understand why they had been refused. And sometimes in that situation, they find it very difficult to think, well, what else might I spend my budget on? Because the one thing that was really important to me has been turned down. So some problems there about being clear about what you can spend the budget on, speed in getting the support plan approved, and trying to avoid those situations where things that people think will benefit them get turned down. And there were also some delays where the PCT was paying for the goods or the services that people wanted to spend their budgets on. And it was the sort of delay of PCT procurement processes, particularly for sort of one-off items. And again, this caused frustration. So, for example, a woman had agreed that she was going to spend her budget on buying membership for the local gym. Typically in January, gyms advertise, enroll now for the year and you can get a third off the price. She couldn't do that, and she tried to get the PCT to take advantage of it, but the process took so long that she missed the advantage of that opportunity to save a bit of money. So again, some delays in procuring goods and services, and some people gave up and actually went and bought the items themselves if they felt they were having to wait too long. Just a small, just a comment on maternity. At the moment, I don't know that maternity personal health budgets are being rolled out more widely for maternity. They're certainly not part of the mainstream kind of rollout. But this was one PHB pilot site which offered budgets to women early on in maternity to help them through, pregnancy, childbirth, and immediate postnatal period. The personal health budgets were offered early in pregnancy. Typically, midwives referred women at the 10-week sort of booking in appointment. Those women were given a list of the kinds of things they could spend the budget on. Most used it for things like relaxation classes, aquanatal classes, massage, aromatherapy, both before and after the birth. One woman, again, it wasn't a definitive list. One woman went off the list and used part of her budget to hire a birthing pool. Two women used it to purchase fast access to physiotherapy because they were having serious pelvic pain problems. So they valued the list of suggestions, but it wasn't a definitive, exhaustive list. Everybody knew that their budget was £500, and all of them had the budget managed by the PCT. And partly because there was this list, sort of menu of suggestions, it appeared that the PCT procurement processes were actually much quicker, much smoother, much prompter. They all talked about the really positive benefits of the personal health budget. They felt relaxed, they felt better prepared for the birth, they felt the birth experience was better, particularly when they were able to compare it with previous pregnancies and births. They felt they had a better relationship with the baby. They felt their families benefited as well because they were just generally more relaxed and confident. And I think one important thing, side thing to mention here, is that these were women with families quite often with a lot of pressures on the family budget. And the fact that it was a personal health budget for maternity gave them permission to spend it on themselves. They said, had they just been given, £500, it would have been used for the children. It would have gone on new clothes. It would have gone on swimming lessons for the children. But in a sense, they were given really positive encouragement to spend it on themselves. So that was just as a kind of sideline. Looking at carers' experiences, as I said, we were interested in the impacts of budgets on people on their caring roles, not on how they thought it was benefiting the patient. There's a very small number here. We ended up with only 13 carers who were interviewed at 9 months. And what was very, very clear were the differences in their experiences. And this is where I think I want to really pull out the differences between carers of people with very severe conditions and very intensive support needs, and where the carers are providing very high levels of support. And carers of people who have perhaps much more easily managed conditions. So in particular, carers of people with serious, severe long-term neurological conditions and who are eligible for continuing health care, compared to, say, carers of people with COPD or diabetes. They were different, but their expectations differed. Those carers of the people with the high support needs expected the budget would have a bigger impact on them. They were also more likely to have their own support needs taken account of in developing the support plan for how the budget would be used. Some of them were taking on responsibility for managing the budget. Some of them felt that they'd done this rather reluctantly, against their will. But others who had already been managing a personal budget for social care were happy to do this because if it built on their existing experience and the existing arrangements. And I want to come back to that point. It's the if is really important. Because there were some implementation problems that we found from talking to these carers. And it picks up a question that somebody asked Julian about the interrelationship between social care personal budgets and personal health budgets. And there were some instances in which there was a lack of clarity about where people had jointly funded packages, jointly funded budgets. The boundaries about is this a health or a social care bath are kind of moved on a bit. And one or two people reported difficulties around, is this a health electric wheelchair or a social care electric wheelchair? So there were kind of disputes going on about what should be purchased out of which budget. And there were also one or two difficulties that carers who'd had long-term experience of managing a social care budget went on to NHS continuing care and found that the PCT was asking them to initiate a whole new set of management arrangements for the personal health budget and for the direct payment that they had through the personal health budget. So again, an example was a woman who'd been told by the PCT that she needed to get references and CRB checks for a personal assistant. She said, I've been employing this personal assistant for 17 years, and now they're asking me to, go through these new processes. So fitting in with existing arrangements or with people's previous experiences was really, really important. And also there was an issue about making sure that the amount of support that the carer received through the personal health budget was commensurate with the level of care that they were providing. There were positive outcomes for carers, although, as indicated, these could be reduced by the implementation problems. People talked about direct benefits. So some carers, for example, the personal health budget had allowed them to purchase more hours of personal assistant help. It had given them a break. It had enabled them to get flexible respite care that fitted in with their family arrangements rather than it having to be, the first weekend of the month. They also reported indirect benefits as well. Some carers talked about how much they felt better because they could see the person that they were supporting was receiving better care, had got a better quality of life, was going out more, had got more outside interests and so on, and more independence. And that created sort of indirect benefits for the carers. So, to conclude, I want to emphasise the holistic nature of the benefits from personal health budgets. It's both physical and mental, and if I was thinking about recommendations for rollout, I would be saying don't tie the personal health budget just to the symptoms of a particular condition. And it may be that what somebody wants to spend their personal health budget on doesn't appear to be directly related to that condition. The benefits are much wider. They are about well-being, and they cross over that physical, mental division. Secondly, that knowing, being familiar with your condition, even if it goes up and down, but being familiar with your condition is important. And people who aren't familiar with perhaps a newly diagnosed condition or a condition which has a very uncertain trajectory will need a lot more help to think about how they're going to spend their budget in ways that will benefit them. There needs to be much greater clarity. Everybody should know the level of the budget, and everybody should be clear about the things that it can be used for and the things that it can't be used for. The thing about knowing the boundaries, being given money, being given NHS money to spend on yourself is really alien to many people, most people, and it's a concept and a practice that people need help with, and they need the clarity of what the boundaries are. Fourth issue is around making sure that once you've decided what the budget is going to be spent on, and it's been agreed that it can be delivered, the services and benefits, services or equipment can be delivered quickly. And fifthly, where social care is involved or has been involved, it's important to align personal health budgets with the practices that people are already familiar with in managing a social care budget. So, thank you.
Thank you very much, Caroline. That was very interesting indeed. I'm sure there must be some questions and comments after that. Straight away, a gentleman in the middle here. That was very quick. If we just get the microphone to you.
Just picking up the issue about what you were saying about a group of people who didn't understand the amount of their budget or what they could use with it. Is there any comparable research in social care about that issue? What I'm wondering is whether in either sector there's a group of people who, just because of their wider level of understanding, have difficulty understanding those issues anyway, or whether there was some deficiency in what the PCT was doing to help them understand.
I wouldn't like to generalise across the sectors. I think, although actually research we're now doing on personal budgets in social care, again, a lot of people don't know what their budget level is, particularly if the budget is managed by the local authority. I think in this instance it may to some extent have reflected the very early status of the pilots at the time at which these people were recruited to the interviews? I don't know, but that may have been a factor. I also think there are processes within PCTs for calculating the level of a personal health budget were less clear and certainly less consistent than the resource allocation system that most local authorities have been encouraged to use and develop for social care. So there may have been quite a lot of juggling and testing things out going on within the PCTs in the early stages of the pilots. And Julian's nodding, so I hope that sounds like a reasonable assumption.
Other questions? Lady there. It's an easy one for the microphone to reach.
Can I ask you, how did you evaluate possible clinical risks where people may not have actually spent the money to support their needs, and that resulted in, risk to them as an individual?